Welcome to the webinar, Periodontal Adjunctive Antibiotic Study. Today, we will be talking about the progress to date since we started enrollments and also about the new patient criteria. We are joined today by Dr. Gilbert, the National Director for the network, as well as Georgios Kotsakis, the Principal Investigator for this study. Georgios Kotsakis is the professor and assistant dean for clinical research at Rutgers School of Dental Medicine. He specialized in periodontal and peri-implantitis therapy, and he's leading the NIH-funded Clinical Research Center at his institution. He's interested in peri-implant bone loss and developing new implant treatments. And as I already mentioned, he's the PI for this study. You all know Dr. Gilbert, but I will just do the diligence here, the due diligence, and introduce him again. He is a distinguished professor at UAB, a campus-wide rank that recognizes international accomplishments. In 2022, he received the Distinguished Scientist Award for the IADR. In 2012, he received the ADA Gears Foundation Award for Outstanding Vision in Dental Education. So Dr. Gilbert is both a researcher and educator. He is the National Director for the network. And today we will be joined by two dentists who are doing this study. Please, let's recognize our research coordinators. Alina Potluri is in the South Central region, and she is here at UAB. Ashley Spencer, it's our regional coordinator for the Southwestern region, and Chris Catlin at the Western region in Portland, Oregon. And the two providers that will be joining us today that are doing the PAAS study, our two champions, are Dr. Olusegun Alonge from Regal Dental Center in Houston, Texas, and Dr. Ian Pham from Family Dentistry in Tualatin, Oregon. So welcome, both of you, and welcome Dr. Gilbert and Dr. Kotsakis. George Kotsakis, now you can go ahead and continue. Thank you.
Thank you very much for the introduction, Joanna, and thanks everyone for being here. It's exciting to see so many people join our webinar, and a big thank you to our node coordinators. I see ARC and NCC staff members here, and I see a lot of our practitioners for moving the study forward. So the intent here is to provide a reminder of our study goals, and then we're going to go a little bit more into specifics of where we are right now and what the intent is for the next steps forward, and how we can potentially engage with new practitioners that are interested in coming on board on our study, because that opportunity exists, and we'll talk more about it as well. So a reminder of the study goals: we're really looking to evaluate the effectiveness of scaling and root planning plus adjunctive antibiotics compared to scaling and root planning with placebo in our trial. And we do that by performing baseline evaluations before scaling and root planning. We perform a short-term follow-up at 6 weeks, and then we follow these patients for their medium to long-term follow-up between 6 to 12 months, depending on the practice and the timeline. I want to talk to you a little bit about the rationale, why we're doing this study and why it's so impactful. I believe everybody probably knows, but it's important to emphasize that antibiotic resistance is currently the #1 killer in the United States, even above opioids. So it's an extremely important topic in terms of public health impact. And the challenge that we face in dentistry is that we don't really have clear guidelines or strong guidelines on when to really use adjunctive systemic antibiotics in conjunction with periodontal therapy, and in which cases it may not be indicated. So the only available guideline that exists right now arises from this study here from the American Dental Association some time ago in 2015, that performed a systematic review and meta-analysis of adjuncts in the non-surgical treatment of chronic periodontitis. Through a systematic review framework, the task force by the ADA came up with a summary of studies that you can observe here on the right-hand side of this forest plot showing you that overall, when you compare all systemic antibiotics that have been used in periodontal clinical trials, there might be a significant but small effect in the range of 0.2 to 0.5 millimeters in terms of clinical attachment gain. Now, can we move, before we move forward, actually, I want to say that although the average benefit on the mean was 0.35 millimeters, and you all know that we can measure in 1 millimeter increments clinically, so that puts into perspective the clinical impact of that overall effect. Was found, but no specific indications were able to be found in these studies because, as you can see in the sample sizes that are in the third and fourth columns, the majority of those studies were smaller scale, had between 10 to 24 patients in the majority of those studies, not allowing to look into a lot of disease-related or patient-related predictors. And the other point is that there are adverse effects associated with systemic antibiotics. There are immediate ones, for instance, anaphylaxis, or less impactful ones, such as gastrointestinal upset or potentially nausea and diarrhea. But there's also a more long-term effect that is challenging to quantify but extremely impactful, and that's antimicrobial resistant bacteria development, and this is the real killer. So overall, because to determine that net benefit rating, we need to weigh pros and cons between the small benefit and potential for adverse effects. Currently, with present information in 2015, at the time of the guideline, the clinical recommendation strength was deemed to be weak. So overall, you can see here the strength of recommendation, and you can observe on the left-hand side of the screen the green color in the area that refers to SRP with systemic antimicrobials, showing that the recommendation from the guideline is that clinicians may consider systemic antimicrobials with a small net benefit expected. Now, how is that translated into clinical practice? In 2022, the latest survey of U.S. general dentists and periodontists by Dr. Ioannidou and colleagues found that 32.4% of participants prescribed systemic antibiotics with periodontal therapy, referring to approximately 1 out of 3 practitioners in the region surveyed prescribed systemic antibiotics. And when it came down to stratification by training, for instance, general dentists versus periodontists, we see a much greater frequency in prescription in periodontists. Approximately half of periodontists, 46.4%, would prescribe systemic antibiotics with scaling replanning versus approximately 20% of general practitioners doing the same. So this survey identified that there's a lack of clarity regarding the timing of prescriptions, factors determining prescription patterns, and the selection of the patient population who would benefit more from antibiotics. So moving forward, our study tries to bridge these issues. So what we're doing is we provide the largest ever randomized clinical trial that has assessed the question, is there an overall effect in prescribing systemic antibiotics in conjunction with periodontal scaling replanning? And if that exists, what is that treatment effect? And it honestly would not be possible to do that without harnessing the power of the NIDCR's practitioner-based research network, and we're leveraging the 3 regions that were mentioned before by Joanna, and we originally enrolled 34 practitioners across these regions with a goal of enrolling 544 patients. Previously, the end of baseline recruitment was in August 29th, and December 30th of 2024. That is now passed, and we've rolled that end of baseline recruitment in August of 29 by allowing people to come back for their final visit, not necessarily at 12 months, but in a broader range of 6 to 12 months to capture that medium to longer term effect of antibiotic prescriptions. And we also had less recruitment rates than expected, as you will see in a minute. And what we did for that is we enabled medication timing to be more flexible, and we'll go more into detail later. And we also, as I mentioned before, changed the follow-up. In addition to that, we also allowed some patient participants to come into the study and only have the short-term follow-up, the 6 to 8 week follow-up after scaling replanning, because that will really show us the maximum effect of antibiotics, the immediate effect, and that is still a great value. Last but not least, we broadened inclusion criteria to really allow practitioners, and all this, by the way, all these changes are being done based on your feedback. So every time we interact with the practitioner, we take that feedback very seriously in our study team, and we come back and make significant changes in the workflow to make it easier for you to adapt this in your practices. And the last changes we did were broadening the inclusion criteria to really enable enrollment of virtually patients with any stage or grade of periodontitis, meaning no matter what the severity of periodontitis is, the patient can be enrolled. So you see here the distribution of patients randomized in our trial, and we currently have, well, at the time of the slides, we had 130 and 183 participants randomized, which is a massive number, and we're very thankful to the community. And the initial goal was to get every practitioner to get 16 to 22 patients enrolled, and we already have some of the highest performing participants already have completed enrollment of 16, and I'm very glad to say that the PBRN actually recognized them with some recognition certificates recently, because all these efforts definitely have to be rewarded. Now, moving forward, you see that there's some discrepancy in certain regions of the country seem to have a better sample population for our study, but overall the recruitment rate is not exactly where it needed to be. I think I just want to be cautious that I pass it on to the right time, but to Dr. Gilbert, but I think, is it still, is this slide still mine?
Yes.
Yep.
Okay, thank you very much. And you will see here that in terms of recruitment rates, the blue line, pretty much a 45-degree line there, is our desired enrollment rate. And you can see here that our total enrollment rate is the orange line, the line right under it. And we're still not tracking. So what we need to do is get that exponential, now that the workflow has been optimized, now that the inclusion criteria have changed. So a challenge we faced in this study is that some practitioners just didn't have the patient population to do that because of the way their specific practice works. So they withdrew, which opens up the opportunity for us to enroll new practitioners, and node coordinators are working very hard in these 3 regions. So we've reopened practitioner enrollment, and there's a renewed opportunity now for you to be part of the PAAS trial if you have not been yet. And with that being said, I want to state that we have outstanding support through the PBRN. These are just examples of the recruitment flyers and the eligibility criteria that we have to make this easily implementable to the practice. And my study team has done a lot of work and has put a lot of emphasis on how do we enable practitioners to really get exposed to research, to contribute to this very impactful research mission, but at the same time, respect that they are practitioners and their specific workflows, and we can't disrupt them. So I will say that, in my view, the study is now as optimized as possible to have an impactful clinical trial performing practices, and we're very excited to continue to working with you all, if you're already a part of the PAAS trial, and to welcome you and discuss the opportunity to collaborate further if you're not yet. So with that, I'm going to pass it on to Dr. Gilbert, and thank you all so much for showing up today.
Okay, thank you, Dr. Kotsakis. So every study we've done involves lessons learned. So since 2005, we have done or are in the process of doing, I think it's 58 studies. And this study is no exception. We typically have a lot of learning as the study initially launches. We make a point of listening closely and listening often, and we're particularly interested in input from practitioners and their office staff as they get the study up and going. So this slide and the next are the result of some of that feedback. And then after I do a couple of slides, I'll hand it over to 2 practitioners who've been particularly effective in this study. So one thing that practitioners and offices have told us, it tends to be very effective, is devoting a little time before the patient even shows up in the office. So the only people eligible for this study are those who are getting scaling and root planing. So the no-brainer is to look at your upcoming schedule and seeing which patients you have scheduled for scaling and root planing, and then drill down from there. So several practices have been particularly successful at doing that. They identify the patients who are getting scaling and root planing in the upcoming schedule, week or 2, or perhaps the entire month. and they already know whether the patient is 35 years old or older. They have some sense of their medical history and whether that might be exclusionary or not. And then if the patient still seems eligible at that point, they will attempt to contact the patient before they show up for that appointment and inform them that we have this great national study going on and they may be eligible for it, and answer any initial questions they might have. And some practices send an informed consent. Some do that plus a patient flyer. And what we're hearing from several practitioners is it's really a function of how well the practice knows that particular patient. So, for example, if this is a long-standing patient and they've been coming in for scaling and root planing over several years, then the practice has developed a high trust level with that patient. And so if the phone call suggests that this person is going to be eligible and seems interested at this point, still, they will email them not only the patient flyer, but the informed consent. That as the practitioners know who participated in this study, the consent form is several pages long. That's required by our institutional review board to make sure that we're protecting all of the participants in an appropriate manner. So it helps if the patient has looked through that in advance. So when they come in the practice, they will have very few questions, and it will not, all this information that they receive will not be coming at them all at once. For patients who don't have this long-term established trust relationship, several practitioners are just emailing them that flyer that Dr. Kotsakis showed toward the end of his slides. That's a front back one-page flyer. It gives a brief overview in the study and talks about some of the eligibility criteria. So then the eligible patient shows up. Hopefully they've been somewhat informed about the study. They are coming in somewhat educated about the study and are potentially interested in it. So when they show up, that discussion can be more efficient and hopefully more effective. And so then the patient's confirmed to be eligible, and then the practice proceeds with the enrollment process. Now, one thing to keep in mind if you haven't started the study is that this is for English speakers only, and that has to do with human subjects regulations that we need to abide by on this study. So that's an additional eligibility criterion. So Brittany, let's go to the next slide. Practitioners are also telling us these lessons learned, some having to do with medication dispensing and getting numbers entered into the database, such as these abbreviations. There tends to be a short learning curve when they start the study to keep track of these abbreviations. It's what individual practitioner startup package, individual participant package, participant ID, and practitioner ID, but that's an easy hump to get over. It's also helpful if you inform the patients they can take the medications with food. That was a lesson learned very early on. We also need the practitioners to upload the period chart images. And some of you may not be on recording bleeding on probing and gingival recession on a routine basis. So it's important to remember to include that in the image that you upload. And this image is not only important because we got to have these data to do a nice job of being able to answer this research question, but it also triggers the patient payment. 6-week re-eval visit. It's good to remind the patient to return the medication in the bottle when they come back. And now we have some leeway about how far after baseline they can come in for their final visit. It can be as early as 10 months. And then Dr. Kotsakis mentioned that the timeline has been extended as well. So we're very fortunate to have on board for this webinar 2 practitioners, Drs. Pham and Alonge, who have been doing the study. They've been very successful at it, and it's better to hear from them directly what seems to be working and not working so well in their practice. So I'll turn it over. Let's start with Dr. Pham first.
Hi, my name is Dr. Pham, and I am practicing in Everyone hear me? Okay, yeah. I'm practicing in Portland, Oregon, and have the opportunity to in small office and have opportunity to participate in this study. So for the study is kind of like first, yes, it's starting very narrow and we able to widening the spectrum so we can recruiting more patients. But I want to share some things with the webinar today is about what I do and see that it worked for my office. I'm not sure about the other office. So first of all, we are a small office. So we have an influx of the patient coming in, and I just have to try to get before to see how many patients can participate in the study. I use the morning hurdle. Usually we have the morning hurdle. We would just look at, see what the patient. So usually daily after work, I go over with the staff about who will come into the office tomorrow. And then from there, I would see how many new patient. So first is new patient. I would look at and see, because it's completely new. So I don't know who will be eligible because so many criteria we have to meet. So I just know that we have the new patient. And then when we start seeing patient, I can just like really quick make a mental note, oh, this patient is how old they are. And then we go over the treatment plan. Then we can see that, oh, this, after I see the x-ray, I can tell, oh, this is probing and everything. We see this is good candidate. And I keep the flyer with me. I don't send it before to them. So I keep the flyer next to me in a drawer when I present the treatment plan, and seem like the patient is really accepted to my treatment plan. Then after I present everything, I would just introduce and say, hey, you are need treatment, deep cleaning, so and so, how many quad, and I would present them another opportunity to participate in the study, and we go from there. So for the next group is the existing patient. The existing patient is, I already developed the trust with them for so many years. So the thing is a little bit tricky with them is they don't need deep cleaning or scaling and root cleaning every appointment. So we do that thing every 2 years. So I have to like make a note and say, hey, this patient is this time they are good candidate, but they are not we cannot do deep cleaning at this appointment. So that would, like, we can rule out this patient or have to wait until 4 6 months or 3 months later, when sometimes we see people every 3 months, sometimes we see every 6 months. We have to say, hey, we have to wait until the 3 months later, then we can recruit them into it. So that is the point. So when we present the treatment, recruit them for the study, I just make myself like, we don't just like sitting back and say, hey, you have to go and help me participate in this study or that study. I would just ask them, politely say, hey, when I present them like the new patient, they have kind of like bad news, say you have gum disease, you have to do so and so. I would say, hey, but you can help us, like we need your help to do this study, and I think you have the opportunity to participate in the study, but you also help to advance the science for everyone. And then the patient can like accepted, then we should go ahead, and I have all the study kit ready. We can start going out. Either we have the iPad, we can sign up and then we reschedule, or if we have more time, then we can just like go ahead and collect plaque or give them the medication, and they can take and wait before we wait. But later on, we got like more time. Either we can start earlier than half an hour. Then About the scheduling is I am just schedule. I have in my office, I have every op has a computer inside connect to the front server. So to avoid the confusion for the patient, because some people have no idea of a study, what it is, they never, maybe that's their second time they see a dentist from the last time they see when they were a child. So I just like eliminate all the confusion. I just set up for them, say, hey, this is, I do it for you. And then next appointment, I schedule the next follow-up. Second skilling or second follow-up, just right in the office and give them either they put on a card or put in their cell phone and they are good to go. So I'm still waiting to see if my research subject can come back at the 12 month or not. So that's still to be seen. And that's all my thing I can share.
Thank you, Dr. Pham. It's really nice to hear how it's working on your practice and how changing the criteria for lowering the age, changing the criteria on the disease helped to increase your numbers, and also removing the medication, taking the medication, the 30 minutes also seemed to help you. So it's really nice to hear that, because we make those changes so that we can have more people participating in this study. I would love to hear now about Dr. Alonge. How has this study been on your practice?
Hello, everyone. Yeah, my name is Olusegun Alonge. I practice in Houston, Texas. You know, the nice part of this is, I mean, I have a research experience, you know, so this is not new to me because I used to be an assistant professor at the dental school. And I've been involved in research in the past. Regarding this particular study, I do have a lot of patients that need SRP. The issue I have with them is, because I usually have discussion with the patients and let them know, you know, that the initial scale and root planing is not the end of the treatment, and you know they need to agree to come in for the perio maintenance in order for me to proceed. So, because I have patients like it's happened to me in the past, after they've had the scaling and root planing, they never came back, you know. So I just try to emphasize that at the beginning. And for this particular study, we're not using flyers or any of such. When the patient comes in for their exam and, you know, a diagnosis is made and there is a treatment plan for scale and root planing, and the patient has agreed to the treatment. So now what I do is now I let them know, you're getting this treatment, okay? There's some research that is going on. Can you help us with this research? And there's some benefits in it for you, you know. We're testing the effect of antibiotic on gum disease. And you know, by taking the antibiotics, you may get some benefits too, as well as the fact that you're going to be receiving some stipends in the mail, you know. And I mean, 100% of the people I've spoke with, you know, they always agree with me. I think because they have a confidence in me, because it's a small clinic, it's a one-man practice, and I do almost all procedures by myself, you know. So that's the pattern that, you know, I've been using at this clinic, you know. So it's just a personal touch, explaining to them. Then the only concern that I have is the time that it takes, you know, so completing the initial part of the consent. So on a day that I have a lot of downtime, I'm able to do everything, give the medication and start the randomization and begin the treatment. For some other days, we just go ahead and, you know, have the patient fill out the consent and schedule to start the SRP on a different date. I mean, that's the, you know, that's the main issue is just the time, you know. it's because it takes a lot of time, to go through the process, But apart from that, I don't have, a lot of issues with getting the patients to agree, So the other issue I have is, I have a lot of patients now that already receive scale and root planing, so I can't put them in the scale in the study. So I'm mostly approaching the newer patients or patients that have been treated for the first time. Yeah, I think that's about it.
Thank you, Dr. Alonge, and it's good to hear your experience with this study. And I would love to hear if others that are here are doing this study, if they would like to share their experience, especially regarding the change in the criteria for enrolling participants, and then also removing the time for the 30 minutes for providing the antibiotics. Would anyone that's here like to share with us? Okay, I will ask a question then. Dr. Kotsakis, can you tell us a little bit more about the rationale for changing the criteria for enrollment and just reinforcing what's the impact of that? Because there might be other dentists here that might be thinking in joining the study, because we still have availability. So you can still join this study and help us understand if antibiotics really work for perio.
Yeah, it's. I think it's part of the reason why we changed the criteria. Really exemplifies how we operate within our study team and within the broader PBRN in a very synergistic fashion with practitioners, in a very interactive fashion. So the feedback that came from the practitioners is that the recruitment rate was lower than expected because of several roadblocks. And we had a lot of practitioners that actually helped us pinpoint what that was. So I think we took immediate action, and we did protocol modifications. We did a lot of groundwork that is needed. So that has been in effect, I think, a little bit over a month. Because of the change in year and whatnot, we haven't seen a substantial effect in enhancing recruitment rates. But I think what this broadening of inclusion criteria does is that it really enables the practitioner to say, if I know I have a patient with periodontitis, more likely than not, they're eligible for the PAAS study. And an observation that I've personally made, and we've discussed extensively with the study team, is that if you're a practitioner who actually performs a lot of scale and root planning, and you wait a little bit before you go into surgical therapy, this study is probably for you. Because if you have the patient population now with broadening the inclusion criteria, that should enable any patient, virtually any patient, to come on board. If you're a practice where you just see a lot of long-term maintenance patients that keep coming back for long-term maintenance and not getting a lot of SRP, or if you're a heavily surgical practice and only wait 4 weeks after scale and replanning to move forward to surgical therapy, then we're seeing that these practices tend to struggle to recruit patients. So there's this understanding here that this study will need to wait at least 6 months for follow-up, and as long as people incorporate that in their practice routine, I think now the PAAS study is very amenable to recruitment.
Thank you. Dr. Gilbert, would you like to share something?
Yeah, just an observation. So we had a comparable webinar, I don't know, I guess 2 or 3 months ago. And then the group there, what struck me is they put a lot of time into identifying potential participants before they showed up in the office. And then today, Dr. Pham, he's kind of in the middle. He does a mix. And then Dr. Alonge, well, not so much. He kind of does it when they come in, and then discusses them when they're in the chair already. So that's kind of classic for our PBRN studies. We try to identify a range of methods that can work, and then the practitioner and their practice staff identify which ones actually work best in their individual practices. So that just really struck me today, that that's that principle in action today.
Yeah, I noticed that too. It's quite interesting to see how office operate in different ways and how to incorporate research into their practice may look different, whether you are depending on how you practice. Dr. Pham, I would like to ask you if you were to give advice to someone that's would like to do this study, what did you learn so far that you would have liked to know if you were starting today that study?
Thank you. I just listen to Dr. Alonge, and something I picked up from him is one thing that when I present a treatment plan for the patient, I have to, I see that he have that thing and I also include in it, but I don't make it really at the last time I talk is, I should also mention to the patient is sometimes we do antibiotics, sometimes we don't, but this one would help for the advanced for their treatment. So I want them to know that this is the game. If they participate in this study, there's something in there for them more than just the monetary compensation, which is if we have the improvement of your condition, so they would be the very first one in society receive that benefit from antibiotic compared with the rest of population, because this is a new thing. Usually we do, periodontists do, dentists do, but we do randomly. We don't have a protocol, as Dr. Kotsakis said. So I just want to emphasize them that, hey, this is a new thing, okay? And there's something there for you. You can benefit from this, participate in this study. That's what I tell the patient. That is the thing I learned. Yes. I just let you know, in the past, I did some, I was in the lab before I was a wet-handed clinician, but I do in a wet lab, doing study some, like every day I go in, I study G protein when I was undergrad. So every day we come in, we pull fruit fly out. So, do something, go to the lab. After I cross my flight, I go to the lab and, mix chemical and do something. And then after let the reaction happen, I go to the fly room, do something. So basically I had the mentality, oh, I can do it anytime I want, but a study with people, you have to time for the patient. Time in the factor is whether people can come in or not, whether people have time for this study or not. Sometimes people say, oh, I will move soon. Sometimes they say, oh, I'm too busy, I cannot. So you have to take into account that this is a real subject, a human with all responsibility and schedule conflict. You have to take those in account in order to recruit success and bring people into the study.
Yeah, I really appreciate you saying that, because it is way more complex in some way when we need to account for those issues.
With human subject is completely different in the lab. You have to plan with them and work around their schedule in order to get them in and get the procedure done.
Yeah, I agree. Thank you for sharing that. See that Dr. Esco, a question.
Here's my question, Dr. Pham. The study aside, how did you decide which patient should or should not have concomitant antibiotics?
I see they have an abscess, a periodontal abscess in the past. If they don't have any pain, I would not. Only thing when I give them something is I would give them antibiotic when I see them have an acute condition, when they have either periodontal abscess or they have some pain or some condition that I'm thinking that would be a serious episode for them, because that thing I have been practiced, and majority the insidious of periodontal disease is it doesn't hurt for the whole time. People have periodontal disease whole time. doesn't hurt majority, and sometimes they have it when they have periodontal abscess. Then at that point, I would treat them with antibiotic.
Okay. And how many sessions of scaling and root planing do they have?
The scaling and root planing, so that also vary, because sometimes I have an acute tooth with obviously periodontal abscess. Then I would treat locally in that thing, because that is sometimes I don't have time to treat the whole mouth. Then I could treat that quad with a course of antibiotic for a week. Then I bring them back, and if that condition settle down, then I will look back entire oral cavity and see what happened to the other quad in the mouth. Because sometimes, you know, that thing can be, we have the problem is in dentistry is endo or perio. Sometimes we cannot tell that is endo problem or perio problem. So sometimes I have to treat to bring the condition down, get them out of pain. Then we will reassess and see either this is perio problem or endo problem. Is that right?
So therefore, all the people that you're offering an opportunity to participate in this study are symptomatic, meaning they're presenting with some
Right.
kind of either acute situation, periodontal abscess, or some other kind of discomfort associated with their inflammatory periodontal disease, just not clinical signs. Is that my understanding?
Right. Yes, I don't have any acute in this study at all. And another thing is, when you bring that thing up, I also want to mention is this: the study require us to record bleeding on probing, but there's something in dentistry. Based on my experience, is many people who are smoker or vaping, they can have bad periodontal disease going on, but they don't have bleeding on probing. Their bone just solidify, the gum just really hard. You hardly to see any bleeding on probing because the periodontal condition. That's what I see in my experience.
Okay, let me ask you about that. So there's no bleeding on probing. I agree, and are their probing depths relatively shallow?
Sometimes it's deep, but they have no pain. And sometimes it's shallow. Then suddenly when their immune system go to a point, then I see suddenly their bone just go, the bone just got destroyed, and the probing depth go up really quickly. Yes, I see that thing too.
So in that situation, the attachment, and this has been reflected in the literature, I think decades ago, their attachment loss is not secondary to bacteria or bacterial induced inflammation. It has to do with an impact on the bone metabolism. So those are not really truly periodontitis patients. Yes, they have attachment loss, but not attachment loss related to inflammatory disease.
And then
I don't know about that.
Dr. Skal, are you saying that's talking about clinical recommendations for when to use antibiotics or not?
Sure, because it's discriminating between what disease. Do you have an inflammatory disease, or are you having attachment loss secondary to another influence?
Okay, yeah, it's an interesting question.
Yeah, that thing can be. We see bone loss, and we see attachment loss, and then the secondary, either anything from smoking to diabetic or variety of condition. That is the tricky part about periodontal disease. Sometimes people, I see the people who smoking, I follow them for years, and yes, there are no bone loss until one day the bone suddenly change. I see that thing many times.
Okay, yeah, thank you for sharing that. What is interesting, Dr. Skal, is that this study will be able to answer some of those questions because we're collecting the data related to bleeding on probing and the inflammation. So it will be interesting to see what is the effect of antibiotic when you are doing the scaling and root planning, because as Dr. Kotsakis mentioned, there aren't been large studies like this that would allow to look at those different profiles of patients. I would like now to give some...
Can I add on to that thing? And you can see that thing is the rate of antibiotic prescribed by specialists and general dentists is the specialists have higher than the general dentist. I think that is, we can contribute that thing is with general dentists. When we see an episode, the bone lot or something that we cannot handle it, we just refer them out. And that thing, all the periodontists always get hit with all the aggressive periodontitis, some episode going on, and they handle it for us. And we just on the other end of the spectrum.
Yes, I noticed that as well. Dr. Kotsakis, would you like to make any comments, any final comments, and then Dr. Gilbert's, please.
Yes, I had raised my hand, but Joanna, you covered it. I mean, this is a beautiful discussion that you have, and we can really provide concrete evidence as of now, and that's where this study comes in. So all this discussion that we had, exactly as Joanna said, will empower us with a very large sample size to be able to look at different subcategories of disease. And the PBRN provides a beautiful framework to do this in a very pragmatic way, to not only include, as often we do in academic studies, we have a very specific subpopulation. We look at, let's say, localized aggressive periodontitis, but rather in the broader range of categories of periodontitis that show up in practices, patients needing treatment to improve their oral health-related quality of life and well-being. What is an effective intervention? And I think we're going to be able to make a statement. So thank you so much for coming. Thanks, everyone, for coming in, and I look very much forward to welcoming you. I am excited we have an opportunity for more new practitioners, so I hope we'll get a chance to work together. Thank you.
Dr. Gilbert?
Did Dr. Alonge have any remaining comments? He unmuted, but they didn't speak.
I was going to encourage the other practitioners, that by participating in the research, they are adding to the body of knowledge regarding management of periodontal disease. And, so they shouldn't have any reservations, about participating in this study. We already prescribe antibiotics for our patients for different reasons. So we do scaling and root planning. So what should be the hindrance or the barrier that should stop anyone from wanting to participate in this study? And, anyone that has any questions, anytime, they can always reach those of us who are already, participating in the study. I mean, that's all I can say. Thank you.
And then my only comments, Dr. Cruz, are that this study is of major national importance. So if you're already a practitioner in study, thank you so much. Please get as many participants enrolled as soon as you can, so we can bump up the numbers. If you're not a participant yet in the study, we've got room for another couple, provided you do it pretty quickly. So please contact your node coordinator if you're genuinely interested and would like to get going on this. So thank you.
Well, I would like to thank everyone that attended today, and especially Dr. Pham and Dr. Alonge, Dr. Kotsakis, and Dr. Gilbert. We really appreciate the practitioners that are doing this study. I also see that a few of the practitioners that are doing the study currently also attended. So we really appreciate the work you are doing, enrolling participants and participating in the National Dental PBRN. And as you know, you receive CE credit today, so please complete the survey after you leave the webinar, and then we will email the CE credits to you. If you have any questions, don't hesitate to contact us at nationaldpbrn@uab.edu. Thank you very much. And the recordings of this webinar will be available. So if you have staff or any other practitioner that might be interested in joining the study, or if you have a staff that is participating in the study and needs some advice on how to increase enrollment, maybe they could be interested in watching this webinar. So we will make it available and will be in our websites. So please visit the website later on. Thank you, everyone, and see you next time.
Thank you.
Thank you.